Welcome. I'm Chris O'Connor from the Heart Failure Collaboratory, and we're here with Heart of the Matter, our podcast, to discuss a site-based research and specifically site recruitment and what are the models for a highly successful program. And I'm here with a very distinguished panel that I'm going to ask to introduce themselves as we go around the panel. And I'll start with Melvin.
Hello, everybody. Melvin Echols. I am the Chief Health Equity Officer for the American College of Cardiology, heart failure general cardiologist, and Associate Director of the Cardiovascular Research Institute at Morehouse School of Medicine in Atlanta, Georgia. So thank you for having me.
Thank you. Maria Rosa?
Maria Rosa Costanzo, heart failure cardiologist, Midwest Cardiovascular Institute in the Chicago area, and very proud member of the Heart Failure Collaboratory.
One of our best advocates, Maria Rosa. Thank you. Anu?
Yeah, my name is Anu Lala. I'm at the Mount Sinai Fuster Heart Hospital. I'm also a heart function cardiologist, one of the co-editors-in-chief of the Journal of Cardiac Failure. And honestly, joining the Heart Failure Collaboratory is one of the best things that's happened to my professional career. So happy to be here.
Oh, thank you, Anu. And Norm Stockbridge.
Hi, I'm Norman Stockbridge. Recently retired from the Food and Drug Administration, now consulting for pharmaceutical companies, large and small. Also happily participating in the Heart Failure Collaboratory.
Thank you, Norm. And Lars, welcome to your first Heart Failure Collaboratory podcast from Denmark. And please introduce yourself to our audience.
Thank you. I'm Lars Kober. I'm a practicing cardiologist from Copenhagen, Denmark, University of Copenhagen. And I'm very happy to have been invited to this. I'm very fond of the idea of studying how to do trials in details. Thank you.
That's fantastic. And again, thank you, Lars, for being here at this late hour for you. Melvin, we'll start with you. Models of success. We talk a lot about the failures in site-based research. We've seen this reduction in performance, from 0.8 patients per site per month in the U.S. now down to 0.4. You've heard some of the examples of really challenging issues with the site-based research investigator. Give us a model that you had established in perhaps when you were in Lumberton, North Carolina, of a very successful program.
I would call this the hell or high water site PI model. And that is basically I had just finished fellowship and jumped into a practice that was not far from where I grew up in rural North Carolina. But the wonderful thing about Robeson County in North Carolina was it was very diverse. And so a third of the population was African-American, a third were white, and then also a third were actually Lumbee Indians, which Native Americans, which actually have a, well-established tribe and community. And so it was really a joy to go into the area that I had known, but really sort of go back to my home kind of area as a doctor. And one of the things that I really wanted to do was bring clinical research to that community because I thought that it deserved it. And I thought that, we could do it. Now, this was a hybrid practice, more of a private practice. And so RVUs kind of rule. But I had a blessing in the wind, and that was Dr. O'Connor, who actually was the chief of our division at that time and really helped me and guided me through that process. And I remember, sort of trying to figure out how to build out this site. And one of the things you suggested, I don't know if you remember or not, but you said, hey, well, why don't you just ask all the docs to give a portion of the bonus that they make to pay for the course? And when you said that, I was like, do you know these guys? Like, I don't think they're going to do that. But I went out and I asked them and they did it. And for 4 years, we paid a portion of a coordinator's salary that actually helped them bring clinical trials that they wanted to do in EP and in ACS and what have you. So over a course of about 6 years, we were able to build out a chartered community research center for Duke. We actually enrolled in over 20 actual trials. We enrolled over 300 patients with 98% follow-up, widely diverse and wonderful community. And so that was where I started sort of this whole kind of passion for clinical research, but you can't do it alone. And so I think that that is the model, and that's why I kind of sit on the hell or high water, because you can make a lot of things happen if you're engaged and you're willing to sort of go to the next level, but you need sustainability and you need balance. And so I think that those were the most important lessons that I learned the first 6 years of my career.
Terrific example. And what I do remember about that, Melvin, is that I was the site PI for the Duke site at Durham, and every time the roster of performance came out, I was always way behind you. So, congratulations. Maria Rosa?
So I had earlier in my career when I was at Rush, I had the distinction of having not one, but two visits from the FDA because they wanted to look at our site due to the fact that we were the highest enrollers in those particular trials. And I also witnessed centers in trials that I was leading where the enrollment was very poor, and that led me to reflect upon what potentially made the difference. And I think there are two very simple but basic things that are important: that the principal investigator or co-investigators are the ones that approach the patient with the study. If you just let it to a research coordinator, I think not that the research coordinator can't do it, but it conveys to the patient that they are not that important. And also, they want to hear it from the person conducting the study. What are the values of participating in the study? And then if it's indeed the principal investigator that approaches the patient, to me, even in 2025, the most important thing is that the patient understands that you care about them and that you are enrolling them in the trial not to use them as a sample, as a research sample, but because you may have something to offer to them that that shows that you care. And one of the things that I used to tell the patients all the time is that even if you get randomized to the control arm, this may allow us to see you more often and to tweak your treatment more often, make sure that nothing happens to you while you are in the trial.
Very, very thoughtful comments, Maria Rosa, and we'll get back to some of those points. Anu?
Yeah, I'm going to get a little personal and share some of my personal experiences in trainee-driven models for site-based research. So Dr. O'Connor knows this because as a fellow, I happened to be at one of the sites that participated in the NHLBI-funded heart failure network. And my mentor at the time, Lynn Warner Stevenson, said, we should really create a network amongst the trainees at these individual sites. And so what was born of that was the Heart Failure Apprentice Network, which is how I met Rob Mentz, who's now my co-editor in chief and a dear friend. It's how I got exposed to you, Dr. O'Connor, and so many other luminaries in the field of heart failure, where I was enrolling patients in trials like DOSE, CARESS, ROSE, RELAX. And then when I graduated, we continued to keep in touch, but we had different people who would take over as kind of running the Heart Failure Apprentice Network. And then as I became an attending, I was equally enthused, committed to enrolling patients in ongoing, not only heart failure network-based trials, but also trials outside of that network, because it had become so ingrained in me that education was not separate from research, and that the passion seed was already planted inside of me. So much so that years later, when a structural organization known as Cardio Nerds approached us to develop a similar program, myself, Rob, and others then served as mentors for mentees in a very similar project. We worked specifically on the Paraglide heart failure study, where again, trainees were the primary people enrolling patients, consenting patients, doing assessments. And so passion seeds were then planted in them as well. And so I think this was mentioned previously as well by Dr. Maria Rosa, but I think the integration of trainees, even medical students for that matter, in the site-based research platform is really the answer moving forward. So I'd say those are two personal models, I think, of success that can be repeated, emulated, and carried forward.
Well, those are great examples, and that giving back and that you've done is such a great example. So thank you for that. We're now going to turn it over to Lars and talk about Denmark, and we're going to give Lars a little more time to describe what's happening there. I want people to be reminded that Denmark's about the size of one of our modest states in the United States as far as population. And when you hear some of these numbers, it's truly remarkable what they've been able to organize in Denmark. But Lars, as you've heard this conversation, talk about the model of commitment of successful site-based research in Denmark.
Thank you, Chris. I would like to take two paths. The first one is, which I can totally echo when I hear your statements, is that if somebody has passion for a trial, dedicated, let that person do that trial. And that has been part of a nationwide collaboration, that if somebody really was burning for something, the rest of the country would say, okay, we endorse that, go ahead. And that was like, okay, maybe not everyone wanted to do the randomization, but then they say, okay, you can go to that person and they will explain you about the child. So patients were moving from hospitals close to each other just to speak with the physician who really cared about that study. So you have a few people who are very dedicated, and they may be, I mean, I have examples of people randomizing 500 patients in one trial from a large uptake area, because everyone just said, okay, we have an opportunity for you to this. Would you like to go to that hospital and hear about this? And then people accepted to do that. And then you had the dedicated person. And I think that was very much in line with the PI really taking care. And patients also really enjoyed being taken care of somebody where they can feel this person wants to do this and there's a good explanation. The other part is that we try to make trials as simple as possible for all those who are going to do some work in the trial. So if we can make it very simple to enroll and not too difficult to make follow-ups, people are more likely to enter patients into trial. And here I also think we have our logistic parts of Denmark with us. We have possibility to do register-based follow-up, which makes it very simple to follow people long-term for hard endpoints. And secondly, we also have the legislation, which is helpful. We can do cluster randomized trials of simple questions with not individual informed consent, but where the departments give informed consent to be a cluster. So patient will be informed there is this trial going out, maybe use your data if you for some reason are given that type of drug. So you're comparing drug A with drug B. And then they say, yes, you can use my data or you cannot. And then, so it's an opt-out situation. So basically, if the patient don't opt out, it's just the um, the patient record system that is selecting drug A or drug B when you order it in your hospital record. You have Epic, we have Epic, we do it in Epic. So Epic is just doing a cluster randomization. And where we normally have cluster as one side, we have had clusters as a time unit. So instead of changing the site for when you have drug A or drug B, it changes with a time unit, and that can be as low as 1 second. So nobody knows what the Epic will say. When you say, I will order an MRA, Epic will say, okay, in this time cluster, it's a eplerenone for heart failure, and in this one, it's spiral. So you actually have in a cluster-based system a perfectly randomized sample. And it's only the departments who have to give informed consent. Patients will be informed and they can opt out for the use of the data. And they're allowed to do that, but they don't.
Wow, that is so innovative, and especially the time. I love the time, and when you reduce it to 1 second, you're exactly right. That's almost like a pure patient randomized trial. What are some of the examples of the sample sizes and times that you're able to enroll in some of the studies? You've done, like you said, comparison of MRAs, you've done comparison of SGLT2s, you've done educational initiatives, you've done carvedilol versus metoprolol. Give us some idea of the sample size in a time period that you're able to do using these types of techniques.
Yeah, we did a pilot in order to test whether we could actually make it work. So we took 2 treatments where we said nobody can say that one is better than the other. I mean, that's even hard to find, but that was 2 different subcutaneous heparins. So we were saying, okay, when people are going to have one of those, Epic will decide. And for that trial, we have randomized 6,000 in a type of trial in the eastern part in Denmark where nobody really cares whether it's drug A or drug B. Like we're doing right now, an SGLT2, one SGLT2 versus another. And I think we have randomized to 2,000 patients in the eastern Denmark or around. I can't remember this, but it's a large number within a year.
May I ask Lars a question?
Yeah.
Lars, what do you think are the cultural, societal underpinnings that lead the patients to be so accepting of being enrolled in trials?
Um, I think when we go for simple trials, they would expect us to do it without asking. So they're almost surprised that we're telling that we're doing it. Oh, didn't you do things like that? They were like saying, we just anticipated you did. So that's one. And basically, I think your point of being dedicated and caring also makes the patients more altruistic, wanting to be part of it, wanting to say, okay, my data, if they can be used, I'm happy to. It doesn't really change. They just have the idea that we're trying to do the best we can do. So of course they'll let their data be part of something where it creates something which is of benefit to coming patients.
That's
And
so terrific.
lastly, I also think that being such a small country with a good infrastructure, we also know that if we are ever going to do a trial where somebody will even read the paper, we need to collaborate together. And we have been very clear in our minds that we need just to collaborate within cardiology in the country.
Thank you. Thank you for your comments, Lars. Norm, pull this all together for us from a regulatory eyesight, what you've heard here and what you've seen over your distinguished career.
And so, in my role as director of the Division of Cardiology and Nephrology and FDA CEDAR, I saw plenty of large trials, and it was not uncommon that there were a handful of sites with good enrollment and a lot of sites with either zero or just a handful of subjects enrolled. And, it led us to, try to make sure that there wasn't a signal in the that there weren't outliers among sites based on what their enrollment looked like, and it wasn't commonly a problem, but it is a problem for companies who pay for sites who don't enroll, and it's in everybody's interest to try and make sure that clinical trials get enrolled efficiently. And you know, we're hearing this afternoon about some people and the lessons they've learned in heart failure trials. There's nothing special about heart failure studies. People in other disciplines probably have similar lessons to teach us about doing efficient trials in the area in which we happen to be interested, but we should be mining other places for what they can teach us. And if indeed, there are therapeutic areas that maybe do this better than cardiology does or heart failure does, we should be especially paying attention to what they do.
That's a really good point, and we often compare ourselves with the oncology networks, and is that structure where there's paid for study coordinators. They don't have to worry about gaps in funding to continue their infrastructure. We're like subcontractors in the construction business. That is, if our trials go away, we have to reduce our workforce or go to zero, but the cancer structure is one that continues. So I'd love to. Okay, we should do as a project in the collaboratory, compare different therapeutic areas. That's a great, great suggestion. Well, we're going to go around the room and just one sentence on what is the best idea to be the best site ever in heart failure clinical research. Melvin? Pick on you first.
You know, I think it's about engagement. I think that on all levels, whether it is, the level of the hospitalist or the trainee or the internal medicine doctor, primary care, and patient and community, it's about engagement of all for the purpose of sort of the clinical trial, but also to speak to the great things that Maria Rosa mentioned about the upstream effects of clinical trial research. I know all of us have seen it. You are better off when people are watching you, and they're available to answer your questions, whether you're taking a control or not. And so engagement, we need to continue to engage the community and our community health workers and people who have actually been a part of clinical trials as champions.
Excellent. Maria Rosa?
Show patients that you care and be willing to share some of your own stories. This actually happened to me just recently, but it underscores the importance of randomized controlled clinical trials. 12 years ago, when I had breast cancer, I decided to enroll in a study called Affinity, which was comparing Herceptin plus placebo versus Herceptin plus pertuzumab. And the follow-up was beyond 10 years. So in July of this year, I was called by the research nurse, and said, I have you uncovered, and I'm going to tell you which arm you were randomized to. And I told her, don't say anything. Let me guess. I was on the placebo arm because I had none of the side effects that I've heard my cardio-oncology patients complain about. And she said, well, you're wrong. You were in the intervention arm.
Wow.
So this shows you that you really need to do the randomized controlled arms and controlled trials. And if this story helps patients to participate, I'm more than willing to share it.
Thank you. You shared it, and that's a great example. Anu?
Wow, I'm totally humbled by that response. So thank you for sharing that with me as well. I'm going to sort of stick to the same generalized theme in a two-part answer. So I think one, as was mentioned, there needs to be a culture shift whereby participation in research as a patient is considered a part of your routine care in cardiovascular disease, as our oncology colleagues do it. It's an assumption that you'll participate in a trial, just like you heard from Dr. Maria Rosa. And as a part of that culture shift, it should also be understood that as a trainee in cardiovascular disease medicine, that you will be conducting clinical trials, that you will be a part of that process. And so I think it calls for a generalized culture shift. And I think that's what's going to allow for sustainable improvements, not only in the current success of site-based research, but also for its longevity.
I think that's so well stated. The culture of the way we practice medicine has to change. Lars, one big idea.
I can echo a lot of what has already been said. So I'll do something else. I would say make sure that there is a good incentive for the people who are doing the trial and for the patients to participate. And I think if you get the incentive that this is good to be part of, then I have a tattoo on my chest. It just says randomize me. So if I ever get to a hospital and I'm sick, they will just see randomize me.
I like that. That's terrific. Norman, you get the last word?
Yeah, but the only last word I have is to echo what you've already heard. Investigators seem to complain about a lot of things, but the thing that works, if it works in Lumberton, North Carolina, the thing that works is the culture shift. It's getting people to participate because it's in everybody's best interest to do things a certain way. And it seems to be general property in Denmark. It's achievable anywhere. It is clearly the place to go is to enhance the communications around participation and convince providers, administrators, and patients that this is all in their best interest.
Yeah, that's so well said. I think what we've heard is that it's a cultural change that we need to make. We really need to make a cultural change. And, if you look at pediatric oncology in the United States, large 70% of children going through the clinics enter randomized controlled clinical trials, in contrast to less than 1% of cardiovascular patients. So the Heart Failure Collaboratory is really taking this on as an important initiative. I want to thank the panelists today. It's been a terrific discussion. We had a wonderful think tank. Melvin's going to be leading a paper on much of this discussion, but this is something we want to continue. Yeah, this is not, as Norm says, something that we're just going to stop and forget. We got to keep this conversation. We got to keep the awareness up and keep the conversation going. So thank you, panelists. Thank you, audience, for being here today with Heart of the Matter, Heart Failure Collaboratory. And until next time, you heard what Lars said, randomize. Thank you.